So thank you, Cam, for that fine introduction, and thanks everyone for introducing yourselves as well. About 60 minutes of slides, but feel free to interrupt me if you have a question. We will have time for questions at the end. Before I begin, a few disclosures. Since I left the military, I have gone into private consulting, and these are my opinions, not those of my institution or of the Army. I am a former Army preventive medicine physician, where many of these insights were first obtained. So for those of you that haven't taken Mefloquine, you're no doubt familiar with this story from the numerous media reports that have occurred over the years, most recently in Canada and Germany, and very soon there'll be a large story in Ireland on a number of suicides that have been linked to their use of the Roche brand of Valerian. This has also been covered by the scientific community. So there's a lot of what I would say confusion and misinformation out there, and I hope to clarify some of this with the talk today. I hope to convince you that in some small respect, some of our post-traumatic stress disorder, some of our traumatic brain injury diagnoses, some of our suicides, and some of our cases of violence in the military are, at the very least, plausibly related to our use of this medication. I won't offer you proof today, but I will offer you enough information that I think a strong case can be made that research needs to be done. This is the original product insert from the Roche brand of Mefloquine Valerian that began to be marketed in the United States in 1989. And as you can see, there are a lot of disturbing symptoms listed in the product insert that don't seem to belong in a drug that targets a malaria parasite. During prophylactic use, if signs of unexplained anxiety, depression, restlessness, or confusion are noticed, these may be considered prodromal to a, quote, more serious event. Now, I would contend that this is a euphemism that has no place in an FDA-approved product insert. We'll discuss a little bit more later what these more serious events could be. Now, I said that Mefloquine plausibly contributes to post-traumatic stress disorder and traumatic injury diagnoses in the military. This is not just my opinion. These are military authors writing in the most recent version of the CDC's Yellow Book. This is the travel medicine's Bible, equivalent to your DSM, if you will. And they state neuropsychiatric side effects from Mefloquine can confound the diagnosis and management of post-traumatic stress disorder and traumatic brain injury, which makes the continued routine use of Mefloquine less desirable. So the military has essentially stopped using the medication it developed precisely because of their concerns over this confounding. But it's not just in theory that this is occurring. The Army has knowledge of actual cases where soldiers were diagnosed with post-traumatic stress disorder in a manner that is really not consistent with the pathophysiology of PTSD. Here's a soldier who was misprescribed Mefloquine in the presence of a contraindicating condition. They were prescribed antidepressants and Mefloquine on the same day. Clearly, you should not do this. And a few months later was diagnosed with post-traumatic stress disorder. So there is at least one case in the military where this has occurred, and as I will argue, probably many more. We know that Mefloquine is strongly associated with violence. It's the only non-psychotropic medication, or only medication not specifically licensed for psychiatric indications, that's listed in the top 10 in this analysis. So something doesn't belong here, and it's the Mefloquine. So what is going on with Mefloquine? We also know that Mefloquine has been causally associated with suicides. This is clear from the literature. And here's a very disturbing case report. I apologize for the grisly images. But as you can see, this is a case that demonstrates features of dissociation, obvious psychotic behavior, which has been causally attributed to the drug. And there have been a number of other causal reports of suicide linked to Mefloquine. Okay, so that is essentially the case I wanted to make. We know from the literature that Mefloquine use is plausibly associated with diagnoses of PTSD, traumatic brain injury, suicide, and violence. So in that respect, I've made my case. What I want to do for the rest of the presentation is describe some of the history of this drug, describe how a drug with these side effects managed to be licensed, managed to be used for so many years without widespread knowledge of these effects. And then I want to get into some of the underlying biology so that we can make sense of these effects. This is a great paper by a colleague of mine in the UK military, Ashley Croft, and he emphasizes the very unusual conditions surrounding the development of mefloquine. Understand that mefloquine was the end product of a decade or even 15-year-long effort where hundreds of thousands of compounds were screened for their antimalarial activity and their toxicity. And of hundreds of thousands of compounds, only mefloquine emerged as a drug that was seemingly free of toxicity and also was effective against malaria parasites. So these tens or even hundreds of millions of dollars that the military invested was riding on this one drug. And the military had very strong political reasons and strategic reasons to see this drug succeed. And it's possible that this created a conflict of interest. Around the same time that mefloquine was being licensed here in the United States by Roche, the World Health Organization became very concerned of reports of these, quote, neuropsychiatric events linked to the drug's use. And perhaps an acknowledgement of growing awareness of these problems, the product insert began to feature the language that I had described. The 1989 package insert said, if signs of unexplained anxiety, depression, restlessness, or confusion occur, these may be considered prodromal to this, quote, more serious event. And they emphasize that in this case, the drug must be discontinued. But what precisely this more serious event is was left undefined. Now, we can guess what these more serious events might be. They describe vertigo, visual disturbances, psychotic manifestations, hallucination, confusion, anxiety, and depression. The product insert also mentioned cases of encephalopathy due to the drug. Now, by 1994, this important point, this lead, if you will, was being gradually buried. They added language that said Lariam should be used with caution in those with psychiatric disturbances because mefloquine use has been associated with emotional disturbances. I say bury the lead because now the association is if you have a history of psychiatric illness, then maybe that explains these outcomes. Not pointing to an underlying toxic property of the drug, but essentially blaming it on the victim. Now, by 2002, this burying of the lead, if you will, had been formalized even more. In a Dear Doctor letter, there were formal contraindications expressed that said Lariam should not be prescribed to those patients with active depression, generalized anxiety disorder, psychosis, schizophrenia, or other major psychiatric disorders. And this, of course, remained undefined. Now, the most recent product insert talks about neurological problems that might be lasting. Dizziness and loss of balance, continuing for months after mefloquine has been stopped, and still this mention of encephalopathy. Now, very recently, you may be aware of this, the FDA announced that it was reviewing mefloquine and conducting a full review owing to their concerns based on reports in the adverse event reporting system of an association with vestibulopathy, with vestibular disorder. A paper that I wrote was featured on a few news stories, and I assume that this was in part responsible for the signal. This paper describes a patient that developed the usual psychosis. It's been known to be associated with mefloquine, but what made this case unusual and interesting was that there were also signs, objective signs, of a central vestibulopathy, a problem with the patient's brainstem, a toxicity that we could say was due to the drug. So, with all of this evidence, and understanding that I'm not speaking to a travel medicine audience, I want us to rethink mefloquine, not as an anti-malarial medication primarily, but like all of the other drugs that were tested during this decades-long drug development effort, many of which were found too toxic for human use. Mefloquine is a psychotropic medication that has intoxicating and also neurotoxic properties. And these neuropsychiatric adverse events that are described in the product insert, these are not vague side effects. These are conserved and highly prevalent symptoms of an intoxication syndrome that's common to mefloquine and other members of the quinoline class. And this syndrome has a number of subclinical effects, but it also has major clinical effects that can occasionally confound and confuse the diagnosis of DSM conditions. And I would argue, and we'll show evidence later, of permanent neurotoxic effects as well. Now, we know that not everyone is as susceptible to the worst of this intoxication. Many people take mefloquine and report feeling okay. I might disagree that they're entirely okay, but Most people say, well, I can handle it. It's idiosyncratic in that some people display a very sensitive intolerance to this medication. And as a result of both these factors, this subclinical effect that might affect many more people than we think lead toxicity and how many people are frankly ill from lead toxicity, but how many people have subclinical effects from it, and the acute symptoms together, this could be a problem with major public health impact. So acute mefloquine intoxication, as is described in case reports, presents as follows. There's usually a prodrome. That can be sometimes subtle and difficult to appreciate, but it's expressed as this unease, a foreboding, mild personality change that might be picked up by the family members, but maybe not by people who are traveling with someone on mefloquine. The package insert warns of anxiety, depression, restlessness, or confusion developing. This can progress to frank paranoia, mania, delusions, or hallucinations, auditory, olfactory, and visual, tremendous anger and aggression, and also amnesia, dissociation, and derealization, which may be behind some of these more grisly reports of suicide. I contend this is a limbic encephalopathy. This is equivalent to what we see in limbic encephalitis, which is a condition very familiar to the neurology community and hopefully also to the psychiatry community. So with limbic encephalitis and to a certain extent limbic epilepsy as a disease model, we can begin to understand the pathophysiology. And if we look for other pharmacological models of this condition, we see it has a lot in common with what's produced by PCP and ketamine, two other dissociative hallucinogens or amnestics. So someone who's suffering the worst form of mefloquine intoxication, they may have a very profound anterograde amnesia, but they'll have preserved implicit memory. They'll know how to do their job as a soldier, even though they may not remember what it is they're doing. And they'll also have tremendous impulsivity without fear of consequences. So we can see from this, from these disease models, there is a tremendous risk of violence and self-harm associated with this frank intoxication. But we also know that mefloquine is neurotoxic, and we know this from the military's own research. Here's a slice of a rat brainstem, and it's showing permanent silver staining in nuclei in the brainstem associated with proprioception, so fine touch sensation from the distal extremities and also location sense. And the author emphasizes that this is permanent, although functional impairments may be temporary because, of course, the brain and brainstem are relatively plastic. This toxicity is permanent. So I argue that many of the acute and chronic side effects of mefloquine, such as vertigo, and this chronic vertigo, which is described in the product insert, this is a symptom or sign of brainstem neurotoxicity, and there's likely limbic involvement as well. And I say this because this is remarkably similar to an effect that was first identified in related quinoline compounds in the 1940s and 1950s that was associated with very frank neuronal injury, and I'll show you this in a second. So the question I have in my research is this neurotoxicity always heralded by limbic systems of intoxication, or can it occur independently of this? And we'll get to that again momentarily. So let's just review. Mefloquine is a substituted quinoline. The quinoline moiety is there on the right, and mefloquine has been substituted with a number of structures that help eliminate its tendency to be rapidly metabolized, and it also makes it more lipophilic, so it accumulates in the malaria parasite's food vacuole, where it exerts its still as yet unknown anti-malarial effect. But the body is able to, in some settings, and I suspect in the highly acidic environment of the peroxisome, it's able to metabolize mefloquine into as yet, I believe, uncharacterized substances that may themselves have toxic properties. We can touch on that momentarily. But here are some papers I discovered from the 1940s that describes very vividly the stark neurotoxicity caused by related quinoline compounds. The symptoms produced by these drugs, as well as the pathological changes, were so constant, striking, and indeed so extreme they merit description. While the entire nervous system was probably affected, at least from a functional standpoint, the brunt of the damage was in definite nuclei of the brainstem. Notably, the mesencephalon through the medulla, the symptoms and signs presented reflected this localization very clearly. Remember, this is a drug closely related to mefloquine. Here's an author L.H. Schmidt, stating that in doses well below the lethal level, these drugs produce striking symptoms of CNS injury associated with severe lesions in the proprioceptive visual reflex and vestibulocerebellar pathways. Their capacity to evoke reactions which might mask symptoms of low-grade neuronal injury. He's describing psychiatric symptoms here. Plus the likelihood of their widespread use in malaria therapy make a detailed search for central nervous system lesions highly desirable. And this was published in 1951. And I'll just draw your attention to his name, Leon Schmidt. Here's a case of human pharmacodynamic poisoning, again a drug closely related to mefloquine. From the standpoint of pathological anatomy, there were ischemic necrosis with reactive change in a small area of the basis pontis, and then mild to moderate degenerative changes notice in the vestibular nuclei. Now, Leon Schmidt worked on this anti-malarial drug development project in the late 1940s during the World War, and then after World War for a few years, and then we don't know what he did during the 1950s, but he was rehired again by Walter Reed in the 60s to develop the next generation of anti-malarial compounds from which mefloquine emerged. So he was investigating the 4 quinoline methanols, of which mefloquine is a member, and notice that similar CNS symptoms were identified. Difficulties in focusing, which should be clear evidence of what? Vestibular, ocular, or ocular gyric toxicity. Lightheadedness, headache, and nausea we now recognize in retrospect are clear evidence of CNS toxicity. Here he is in 1951 saying their capacity to evoke reactions which might mask symptoms of low-grade neuronal injury make a detailed search for central nervous system lesions highly desirable. Now, in the 1940s and 1950s, the U.S. military conducted very careful animal histopathological testing, doing very careful brainstem studies of the toxic effects of the drugs that were under development during that era. To the best of my knowledge, this testing was not repeated during mefloquine's development. Instead, it was immediately rushed into phase 2 trials. And here is a paper published in 1975 commenting very clearly on the CNS effects of mefloquine. Transient dizziness and nausea within the first 48 hours. In retrospect, it's easy for us to identify this as evidence of CNS toxicity. But incredibly, the FDA did not even know the drug penetrated the blood-brain barrier. Here's a transcript I found of a subsequent licensing talk in 1991 after the drug had been out for a couple of years and they were considering increasing the dose. Dr. Maxwell said, we couldn't really find data on the CNS penetration of this drug. So I conclude from this that those individuals responsible for licensing the drug and deeming it safe and effective didn't even know about the CNS toxicity of closely related quinoline compounds. But, all they had to do was read the new drug application that Roche provided them, because it says right in there that the brain is a major compartment of mefloquine accumulation. And here's what's interesting. In 1978, so 3 years after that first human trial was published, here's Dr. Schmidt again. And I sometimes wonder if this is a very wise man who is choosing his words very carefully for posterity, knowing that one day someone like me would be reading his paper. He says, mefloquine promises to be broadly useful, both in treating established infections and for routine suppressive purposes. If this promise is not realized, it will doubtless be not for lack of antimalarial activity, but rather because of toxicological attributes not identified in the small-scale studies pursued to date. And I'll reemphasize that Dr. Schmidt did very careful brainstem testing of the neurotoxicity of related quinoline compounds in the 40s and 50s, but does not seem to have either chosen to do that or, I presume, was not able to do that testing when mefloquine was under development. So, from this, we conclude that the authors that knew of this very strong class effect, this anti-malarial neurotoxicity class effect, that were involved in mefloquine's development were intimately aware of this from the 1940s. And unlike the very careful testing that was done on these drugs in the World War II era, there doesn't seem to have been any done on the 4 quinoline methanols, including mefloquine. And these symptoms, including dizziness and vertigo in the phase 1 and phase 2 trials, which were all over the place, they don't seem to have been recognized by anyone during development as corresponding evidence of CNS toxicity. And pre- and post-marketing signals as to this toxicity have been routinely overlooked and are overlooked to this day. And how and why did this happen? Well, I think we can surmise why this happened, and it relates to what Dr. Croft talked about, the unusual circumstances of the drug's development. Okay, so that's in the past. We can't change the past, but we can understand this syndrome a little better today. I contend that mefloquine neurotoxicity is, at least in some respects, in some way, responsible for some burden of post-traumatic stress disorder, traumatic brain injury, suicide, and violence in the U.S. military. But why and how? How can we make sense of this? So let me see if I can develop for you a theory of mefloquine toxicity. And this will appeal more to the neurobiology side of psychiatry. We'll review the epidemiology, the pharmacokinetics of the drug. We'll review the neuropharmacokinetics, because that's the kinetics that counts. And then the pharmacodynamics. So we know that these adverse effects of mefloquine occur more commonly at treatment doses than prophylactic doses. And we know that early effects seem to predominate rather than late effects. We think that females are more susceptible than males, but there's some uncertainty. And then there's a question of whether a history of mental illness predisposes, and that's equivocal. But what we do know is that adverse events can occur across populations. They can occur to anyone, and it occurs in a very idiosyncratic manner. You discover who's susceptible to mefloquine toxicity by giving people mefloquine and figuring out who doesn't tolerate it. So let's talk about the pharmacokinetics. Mefloquine is very, very lipid soluble. I think it's the most lipid soluble drug we have in the formulary today. The point here is that an anti-malarial drug should have serum as a compartment, because this is where the malaria parasites live, in the serum. Well, not in the serum, they live in the erythrocytes. But you want the drug to concentrate in the circulation, not the organs, because it doesn't do any good in the organs. At least a schizanticide like mefloquine doesn't do any good in the organs. But serum is not a major compartment for this drug. Instead, its volume of distribution is an incredible 20 liters per kilogram. And as a result, it takes up to 7 to 10 weekly doses for mefloquine to achieve, in some cases, therapeutic levels in the serum, which means you can return home from your vacation having never achieved reliable antimalarial activity, all the while having experienced psychotropic effects. Think about that. So I'm just going to review some pharmacokinetic studies to show you this wide range in pharmacokinetic parameters. Here's a study that was done in 2001, and you can see this very extreme range of values. But here's the important thing. This was a study that was done looking at the association between blood levels and propensity to adverse events. And of course you wouldn't expect an association, would you? Knowing what we know now, just sitting in this lecture about what fraction of the drug really goes into the serum, why would you expect serum levels to in any way correlate with adverse events? You need to measure concentration in brain. And this is a very poor proxy for brain concentrations. So tremendous variation in this study. Here's a study of military personnel. And we can see, again, tremendous variation across time and even between days. So this very wide range in concentrations, I think it's often been viewed as a benefit of the drug, as a plus. But I would say this is actually a minus. Here's one of the largest studies done to date, over 1,000 subjects. And so we see this very, very large number of data points. And you can see there's extreme outliers. But also notice there are a large number of subjects, and compliance was confirmed in this study. So you have a large number of subjects who really remain subtherapeutic. So all of these individuals are not deriving any antimalarial benefit from the drug. And these individuals here have far, far, far too much mefloquine in their system. So a very, very wide range of serum levels, not to mention concentrations in other organs. Here's one of the earlier studies that came out, first raising alarms as to the dangers of mefloquine. Subjects administered just 750 milligrams for treatment, all of whom had adverse effects of the drug, and again, a very wide range. But here's what's interesting, right? So we know that treatment doses of mefloquine are associated epidemiologically with a higher risk of adverse events, right? We know this from years of research. But the serum concentrations achieved are relatively identical. Right? So chemoprophylaxis, which involves taking 1 pill a week, we think lower risk of side effects. Same serum concentration as if you give the drug 5, or in this case 3 tablets all at once for treatment. Much higher risk of side effects. So it seems that risk of side effects correlates not with serum concentration, but with dose rate. Now we know that the pharmacokinetics varies by ethnicity. This has been demonstrated in a number of studies. And as someone that works in the field of mental health genetic epidemiology, I'm always interested in ethnic differences. If they can't be attributed to diet or some cultural factor, maybe they can be attributed to genetics. And here we see lots of good evidence that the pharmacokinetics of mefloquine varies by ethnicity. So what could this mean? Maybe there's a genetic origin to the pharmacokinetic heterogeneity. So let's review the pharmacokinetics of mefloquine quickly. So a 250 milligram tablet of mefloquine, on average, will result in serum levels of 250 nanograms per milliliter, which is roughly a fourth of what you want it to be for reliable antimalarial protection. So you see from this that the average person needs roughly 4 tablets for this drug to be an effective antimalarial. But some people achieve effective levels in 2 doses, some in 3, and some will take 7 or 10 or more doses for this to be an effective antimalarial. But on average, only 1 to 2% of this drug, that tiny little sliver shown on the right, ends up where you need it to be in the circulation. Why is there significant variation? And where does the remaining mefloquine go? Well, we know where mefloquine goes. It accumulates in brain. This paragraph, which was included in the new drug application, clearly states that persisting levels were found in the heart and brain. On a percent dose basis, the most important pools occurred in the liver, lungs, muscle, and to a lesser extent, the brain. So here's a model to understand this. And I use the metaphor, the analogy of living in New Orleans. You're living below sea level, so the water wants to get into your city. And the only way you're not flooded out in New Orleans is if the pumps are working and the city is pumped dry. But the pumps have a finite pumping capacity, so they can only pump out so much water at a time. If it drizzles long enough and the pumps break, you're going to get flooded. If there's a sudden thunderstorm or a hurricane pouring through, no matter how strong your pumps are, you're going to get flooded. So it doesn't matter the dose. What matters is the dose rate and whether the pumps are working. Is that metaphor clear? Here's a visualization for you. So over time, as we move to the right, this serum concentration leads to rising brain levels. And eventually, the body's xenobiotic transporter system will kick in and begin to pump this toxin back out of the brain and into the circulation. And we know that mefloquine is mediated by P-glycoprotein. So over time, perhaps a day or 2 after dosing, your PGP will kick in and try to pump the mefloquine out of your brain where it's exerting harmful effects. But what happens if this pumping is impaired? What happens if your pumps are broken? What happens if you have a defective, if you will, efflux system? Or what if you just dose so quickly that you flood the pumps out? Well, then you'll have very high brain concentrations of the drug that could exceed some theoretical toxic threshold. Does that make sense? So here's a model, if you will, of mefloquine neurotoxicity that integrates what we know about the drug. And let's look at some studies that are backing this up. So here's a study looking at mefloquine transport across barrier membranes, and we see that it's impaired by P-glycoprotein substrates and antagonists. Here's another study looking at this PGP inhibitor, not a licensed pharmaceutical, but good for studies. And again, we see that in the presence of this PGP inhibitor, brain concentrations double. And what's important to note is that the serum concentrations don't vary here. So twofold variation in brain concentration with no perceptible change in serum concentrations. And of course, this is what we would expect, right? Because the studies show no consistent association between serum levels and CNS adverse effects. Remarkable how these high CNS concentrations persist for a long time in the presence of these PGP inhibitors. There's a lot of PGP inhibitors out there, and many of you in psychiatry will use PGP inhibitors. And what I find interesting from a genetic perspective is that one of the enzymes we think metabolizes mefloquine is located very nearby to the gene which codes for PGP, right? So from an evolutionary perspective, this is some evidence of a conserved xenobiotic mechanism that's designed to protect the body from dangerous xenobiotics. And of course, look, when you take mefloquine, your body is telling you it's a xenobiotic. Your body is telling you it's dangerous. It's bitter. It evokes an emetic reaction. It makes you sick because it's so bitter. And your body is trying to vomit the drug out. So if that first line of defense fails, the second line of defense takes over, the PGP efflux and metabolism conserved in the small area of chromosome 7. Now, I've said that mefloquine affects certain areas of the brain more. It's not really cortical, is it? It's more limbic and it's more brainstem. So how could this theory explain this? Well, we know that the expression of PGP is lower in the limbic system. We know this from rat studies, and hopefully this is true also in humans. So perhaps the absence of baseline PGP expression in the vessels of the limbic system explains its accumulation in that region, preferentially over the cortex. Perhaps. This is a speculation. But we have enough information from the literature to develop this hypothesis, a testable hypothesis. So based on what we know about human PGP and some animal model studies, we can surmise that if there are polymorphisms, genetic polymorphisms, in the gene that codes for this pump, that either affect how the pump operates or, perhaps more likely, affects how it's upregulated in response to certain xenobiotics. And that could result in an idiosyncratic susceptibility where individuals are not able to as effectively efflux the drug from their brain. And that might be the primary mediator of intoxication and neurotoxicity. And in fact, some authors in the Netherlands tested this, and they found a reasonably strong association with some commonly studied SNPs, single nucleotide polymorphisms, in the MDR1 gene, correlating with adverse effects. In this study in women, not in men. But it's intriguing, to say the least. Okay, so we've talked about the epidemiology, we've talked about the pharmacokinetics and neuropharmacokinetics, and now let's talk about what mefloquine might do once it accumulates in the brain at these levels. So we know from the literature that it has direct synaptic effects, but it also has these intriguing effects on what scientists recognize is an important component of neuronal communication, direct electrical synaptic communication through connexins and pannexins. And we'll also talk very briefly about the potential excitotoxicity of this drug. So reviewing this quick, I'll refer you to the literature if you want to study these more, but we know that mefloquine has an effect on the GABA and serotonin receptors at concentrations which are physiologically plausible in the brains of those suffering from intoxication. So some serotonergic effects, some GABA-A receptor effects. This has been confirmed as a class effect of the quinolines. Here we see an obvious effect from fairly reasonable doses of mefloquine. But I find this much more intriguing because there's been a significant body of literature describing behavioral correlates with gap junction blockade. There aren't, as far as I know, with the exception maybe of modafinil, there aren't any psychiatric drugs that directly target gap junction communication. But neurons communicate directly through little holes that are created in their membranes by these proteins called connexins. And here we have a little cartoon demonstrating this. The connexins are a class of proteins. They come in different sizes, and so the number represents their molecular weight in kilodaltons. The connexins of interest in mefloquine toxicity are connexin 43 and connexin 36, and essentially mefloquine is a potent blocker of these gap junctions. Connexin 50 is not really found in the nervous system, so we'll focus on connexin 36 and connexin 43. Connexin 36 is very, very sensitive to mefloquine at extremely low doses, low concentrations, to the point where I expect almost everyone taking mefloquine should have complete connexin 36 blockade. I don't understand how people don't taking mefloquine. And it's possible that connexin 43 blockade occurs in a subset of users. So here we have measurable effects on electrical communication between cells in an experimental model, again at concentrations that are relevant, 10 micromolar. And ever since this discovery, the neurobiology community has been very interested in using mefloquine to study these basic neurophysiological processes. So there are a number of papers not written from the psychiatric perspective or not written from the clinical perspective, but written from a purely neurophysiological, neurobiological perspective. And they don't really speculate on the clinical effects of mefloquine, but the behavioral and physiological effects they're describing are quite profound. So here's an example of how there may be some compensatory mechanisms that develop in the presence of connexin 36 blockade. Here's an interesting paper. Let me see if this. Yeah, that's right. So here's a very strong effect from mefloquine. Reduces synaptic inhibitory and excitatory transmission. A series of papers published by this team out at Brigham Young University looking at the effect of mefloquine on the VTA and reward mechanism pathways. Very interesting effects of mefloquine. So effects on reward learning attributed to mefloquine. Here's an interesting paper I assume was funded by an alcohol grant that shows measurable behavioral changes in mice dosed with mefloquine. And here's an interesting paper that describes the effects of mefloquine essentially on the ability to learn new motor memory skills in the inferior olive. So reasonable and physiologically plausible doses of mefloquine are affecting numerous areas of the brain. But of interest to this group, it's also affecting many more important structures, the amygdala, for example. And here we see that mefloquine counteracts the effects of anxiolytics. And what is going on? Well, there's a speculation that there could be, by affecting interneuron inhibitory tone, this is how the drug might be exerting its effects. So if you disrupt the coordinated interneuron inhibitory activity, you have a disinhibition. And that might be what's going on with mefloquine intoxication. Electrical communication is also important for sleep-wake control. Here we have a study looking at the effects of modafinil counteracted by mefloquine. Maybe modafinil opens up gap junctions and mefloquine is blocking them. That's speculation. But perhaps the most interesting paper came out of California not too long ago. And I'll just present this really without much interpretation, but he's studying the effects of mefloquine on fear learning and specifically on context fear learning. So there's certainly enough biological plausibility to appreciate the potential role of this drug in the idiopathophysicology of conditions whose pathology centers on these structures, right? The hippocampus, the amygdala, the LC. Okay, so I've demonstrated that the mefloquine blockade of connexin 36 gap junction communication has a lot of plausible effects, right? Could this explain the prodromal symptoms, the sleep changes, the dreaming, the anxiogenesis, the changes in risk-reward behavior, some of the effects on short-term memory, the amnesia? Could this be enough? Could connexin 36 blockade explain it all? My concern with that is that it's so exquisitely sensitive to mefloquine blockade. I don't understand why more people don't experience these problems. Or could it be something more? Could it be this connexin 43 blockade? And I'm not going to, for the benefit of time, I'm not going to discuss some of the latest research on connexin 43 blockade. But connexin 43 is being increasingly investigated by the neuroscience community for its role in cellular death and glial death after trauma. And there's a big debate in the neuroscience community as to whether gap junction communication through connexin 43 gap junctions serves as, in their words, an executioner after traumatic brain injury or after ischemic injury, that apoptotic signals might travel through these open gap junctions. Now, one might think then that administering a drug that blocks these connexin 43 gap junctions might be therapeutic, right? Maybe mefloquine protects against the effects of traumatic brain injury, but possibly not. In the same way that connexin 36 seems to have compensatory mechanisms developing under conditions of blockade, maybe there are compensatory mechanisms. Maybe connexin 43 is upregulated in the presence of mefloquine. Maybe there's more potential executioner channels opened up in soldiers taking mefloquine. And so when they suffer a trauma, when they suffer a head injury, maybe there's more ways for the apoptotic signals to spread. I don't know. But there's enough plausible information in the literature that we should be studying the role of connexin 43 blockade on brain cells after trauma. And then lastly, we've been talking about quinolines. And for those of you that are interested in some of the research being done on Parkinson's and Huntington's, you'll recognize this is a familiar term, right? Quinolytic acid, this endogenous neurotoxin, which is part of the kynurenine metabolism pathway. Quinolytic acid causes a lot of brain and brainstem neurotoxic lesions that seem very similar to what we've been describing. So my question is a very simple question. Is quinoline metabolized by the brain somehow to quinolytic acid? And if it is, then we have a very parsimonious explanation for many of the things that we're seeing, because quinolytic acid is an excitotoxin that acts on NDMA receptor pathways. So it could explain a lot of the acute behavioral effects that we're seeing, and it could also explain some of the brain and brainstem lesions that we've identified. It's never been reported in the literature, but there are a number of patents describing under acidic conditions the metabolism of quinoline to quinolytic acid. So I think it's intriguing, to say the least. Okay. So I've proposed this condition, mefloquine intoxication syndrome, which is really manifesting as a limbic encephalopathy. And clinically, it's very similar to what we see in the anti-NMDA or limbic encephalitis, right? And we know what this looks like from the neurological literature. It's sleep disturbances, it's vivid dreams, it's mood changes, serving as the prodromal indicators of this developing dose-dependent syndrome. And normally, I'm going to propose individuals that have functioning PGP, maybe this gene will be upregulated, MDR1 will be upregulated, the body will pump the mefloquine out of the brain and stave off the worst of these effects. But in some individuals, either they're dosed very quickly and the body can't keep up, or the gene polymorphisms prevent upregulation or proper functioning of the gene. The brain is flooded with mefloquine, it's lipophilic, it tends to accumulate in the brain naturally without any effort, and the rising brain levels result in these psychotropic effects that we've described due to receptor effects, gap junction blockade, and also potentially the excitotoxic effects that I've speculated to. So that is the theory that might serve to explain everything we've observed. Okay. We're not quite done explaining things yet, though, because the package insert describes contraindications to mefloquine, right? You shall not take this drug in the presence of contraindicating conditions. Well, why is that? Does someone who has a mental health history, are they at constitutionally increased risk of toxicity? Is there something about the neurobiology of depression or schizophrenia that makes their brains more susceptible to the drug's toxic effects? And how is it that disparate mental disorders can serve the same constitutionally increased risk? To me, that doesn't make sense, right? What if it's simpler than that? What if, when we look at the product insert and we read it carefully, we see during prophylactic use, if signs of unexplained anxiety, depression, restlessness, or confusion are noticed, these may be considered prodromal to a more serious event, and in this case, the drug must be discontinued. Aha. So if you have a history of depression, if you have a history of anxiety, then maybe you're going to attribute these symptoms not to the drug's toxicity, but to your pre-existing condition. And so you'll continue to take the drug in the presence of these prodromal symptoms. And so the brain concentrations will increase, you will become more intoxicated, and now you're unable to discontinue the drug because you're suffering the paranoia of frank intoxication. And this will end in your suffering long-term effects, a more serious event, in the words of the drug manufacturer. So I contend that a pre-existing mental condition makes it less likely for you to follow the package insert guidance, And simultaneous use of psychotropics will confound your recognition of these prodromal symptoms. But you see that other things serve the same effect, right? Not receiving good education at the time of prescribing serves the same effect, doesn't it? Or serving in the military where you're told you must take this pill every week serves the same effect, doesn't it? Because all of these things make it less likely that you will recognize intoxication and discontinue use of the drug at the onset of these prodromal symptoms. So that is my theory. I think I'm right. I think that this theory explains both the epidemiology of mefloquine intoxication and neurotoxicity and provides a very parsimonious explanation for everything else we've seen with the related drugs. So we know that treatment doses have a greater risk of side effects than prophylactic doses because the dose rate is higher, not because the dose is higher. You're getting more drug in less time, and so you have less chance to pump it out of your brain. Dose rate is higher, not dose. Early effects are more common than late effects, probably because over time your body upregulates expression of this efflux transporter. And this is the tolerance that many people report developing on mefloquine. Females will, per unit dose, experience a higher change in brain levels, right? So they may experience, per unit dose, they may get a stronger initial effect. They may also be more likely to discontinue the drug in this case. I see more long-term problems with men who continue to take the drug and maybe they just get used to it over time. And so they get used to the toxicity, whereas women, they get this big bolus into their brains and they say, forget it, I'm not taking any more mefloquine. And this personal history, I think, can be explained by a failure to recognize prodrome and discontinue the drug. And then the idiosyncratic susceptibility, I think, is due to these polymorphisms in MDR1. Chronic symptoms, though. There have been no studies evaluating individuals that have taken mefloquine 5-10 years later to see if they experience long-term problems. So we can't rule them out. We don't have any evidence that this isn't occurring. And we have plenty of anecdotal stories of people suffering lifelong disability from the toxic effects of this drug. And there are many plausible explanations for this, right? PTSD is a perfect example of a short-term exposure that results in permanent disability. And at a cellular level, what's going on? The trauma that they see or hear or smell or experience is translated into some kind of electrical activity in their amygdala and hippocampus, and this results in some type of long-term change that is associated with the disabling features we recognize. So it stands to reason that a drug that induces a similar disruption or shock to that part of the brain could also result in long-term symptoms. It's biologically plausible, right? But we also have pictures like this that show brain stem and brain lesions from the drug. So certainly direct damage to the limbic centers or brainstem nuclei could explain these long-term effects. And Roche has never satisfactorily responded to the question of, well, how do you explain this? Right? This is neurotoxicity. There is no safe neurotoxin. If there were, we would be using leaded gasoline in our cars. So I would propose that epidemiological studies must look at any history of mefloquine exposure, not just recent exposure, in order to be methodologically valid. Okay, so what are the probable or plausible chronic symptoms of mefloquine toxicity? And a lot of this comes from my experience and the experience of those that I've worked with describing these syndromes to me, and it makes sense from the literature with what we see with limbic encephalitis and also with brain injury. Personality and mood changes are very common, particularly irritability. Irritability is very common. Sleep disturbances, nightmares. You would almost think you're dealing with post-traumatic stress disorder in some of these patients. Many nightmares. And also, sometimes it's apnea. It's almost a central apnea in some patients, but we can talk more about that. Memory and cognition changes. Virtually, we're dealing with mild cognitive impairment in a lot of these patients, particularly spatial and working memory. These patients are always consolidating their frequently lost objects. They're always putting their things in one place because they have no chance of remembering where they leave things. Dizziness, vertigo, and disequilibrium, an unusual gait, an unusual stance that almost seems aphysiologic, is very common. And then visual or vestibular sensitivity. This has been described. It's the supermarket syndrome. People are very uncomfortable in supermarkets, in marketplaces. And those of you that study Greek should recognize this syndrome, agoraphobia, fear of the marketplace. Now, agoraphobia has traditionally been understood as a fear of settings where help is not readily available. But I would argue that there's an endophenotype, a subset of agoraphobia, that's actually a fear of loss of visual inputs, of vestibular stabilizers. If you go to a very crowded place, a marketplace, a stadium, somewhere where people are moving around, if you have mild vestibulo-ocular dysfunction in your brainstem, you're losing your visual references. And now your brain has to compensate. You need to use conscious thought to keep your head stable, your body stable, and your eyes tracking. It overwhelms you. It's like trying to carry on a complex conversation when you're driving in rush hour traffic. You become very frustrated. You need to focus on the task at hand. So I think some of the agoraphobia we see in individuals suffering from mefloquine toxicity is actually, it's mediated by this vestibular toxicity. And then people will suffer what they describe it as going dizzy, but it's not going dizzy. They're experiencing mental shutdowns. Their brain is shutting down every few weeks, every few months. Is this limbic seizure disorder? We know that related quinolines can cause lesions in the hippocampus and the amygdala, other areas of the midbrain. So is that kindling a limbic seizure disorder that could explain the waxing and waning presentation of this long-term syndrome? I've described enough symptoms, I think, to convince you all that this could confound the diagnosis of post-traumatic stress disorder. And certainly if someone's suffering cognitive problems and they've been overseas and you just don't know what's wrong with them, it's easy to say, well, you were in the military, it must be a TBI, right? I hope that's plausible. But because the neurological symptoms are so unusual, and because you're dealing with multifocal injury to a number of very critical brainstem areas, I would argue if you're dealing with a patient and you strongly suspect personality disorder, malingering, factitious disorder, somatoform disorder, and they've taken mefloquine and they describe a reliable history of some degree of acute effects from the drug, I think it's mefloquine toxicity until proven otherwise. Because this part of the brain and brainstem is too complicated. We can't say we understand it all. And I've seen many, many patients, and Gene can describe some to you, that even experienced neurologists and neurotologists that know they've suffered brainstem injury from the drug. It looks like they're faking it, but they're not. This is brainstem toxicity from the drug. Okay, so that's a fairly fast overview of the topic. Let me describe briefly what it is that I do at Johns Hopkins. So I'm very interested in genetic studies, but in mental health, genetic studies are just they're very difficult to do, right? Because without an accurate phenotype, you're in trouble. So I want to precisely define this phenotype. I want a very solid case definition for mefloquine toxicity, and we have plenty of evidence to do that from case reports and FDA data. The genetic epidemiological studies I will share with you at the next talk that Dr. Ritchie and I are doing at 1:30. I have some intriguing results from a study looking at PTSD and MDR1 genotyping. And I'm interested in doing the long-term studies that haven't been done. We have a group of veterans, the Somalia era veterans, that have been out now 20 years. And many of them are coming forward with unusual symptoms, to say the least. So I'd like to do a study on this group. And then lastly, qualitative research is underappreciated. I'd like to do some good qualitative studies and learn the experiences of individuals that have experienced problems from mefloquine. Learn what went wrong. How is it that they developed frank intoxication, even though the product insert says if you experience prodromal symptoms, you must discontinue the drug. What went wrong? Was it command-directed administration that made them continue taking the drug? Did they just not know? Were they told, oh, these side effects are rare, and so it can't be happening to you, keep taking it? I think qualitative research of that kind is very valuable. So thank you very much for your attention. Kim, I'll turn it over to you, and then we have time for